Our next talk is general drug information regarding ERLA opioid analgesic products. Prescribers should be knowledgeable about general characteristics, toxicities, and drug interactions for these products. For example, ERLA opioid analgesic products are scheduled under the Controlled Substances Act and can be misused and abused. Remember, respiratory depression is the most important serious adverse event of opioids, as it can be immediately life-threatening, and constipation is the most common long-term adverse event and should be anticipated. You should know your drug interactions and your prescribing information. Prescribers should be aware that drug-drug interaction profiles vary amongst the different substances. Knowledge of particular opioid drug interactions and the underlying pharmacokinetic and pharmacodynamic mechanisms allows for the safer administration of opioid analgesics. CNS depressants, alcohol, sedatives, hypnotics, tranquilizers, tricyclic antidepressants can have a potentiating effect on the sedation and respiratory depression caused by opioids. Some ER opioid formulations may rapidly release opioid dose dump when exposed to alcohol. Please remember that. Some drug levels may increase without dose dumping when exposed to alcohol, so you must see the individual product labeling. Using opioids with monoamine oxidase inhibitors may result in possible increases in respiratory depression. Using certain opioids with MAOIs may cause serotonin syndrome. Remember that. Opioids can reduce the efficacy of diuretics by inducing the release of antidiuretic hormone. Some opioids, particularly methadone and buprenorphine, can prolong the QT interval. With methadone, cases of QT interval prolongation and serious arrhythmia, torsade de pointe, have been observed during treatment. Most cases involve patients being treated for pain with large multiple daily doses of methadone, although cases have been reported in patients receiving doses commonly used for maintenance treatment of opioid addiction. A positive controlled study of the effects of transdermal buprenorphine on the QDs interval in healthy subjects demonstrated no clinically meaningful effect at a transdermal buprenorphine dose of 10 micrograms per hour, but at a dose of 40 micrograms per hour, there was an effect. Concomitant drugs that act as inhibitors or inducers of various cytochrome P450 enzymes can result in a higher or lower than expected blood level of some opioids. The concomitant use of ERLA opioid analgesics containing buprenorphine, fentanyl, methadone, or oxycodone with CYP3A4 inhibitors may result in increased opioid plasma concentrations and may cause potentially fatal respiratory depression. Let's talk a second about tolerance. Tolerance to sedating and respiratory depression effects of opioids is critical to the safe use of certain products, certain dosage unit strengths, or certain doses of some products. Patients must be opioid tolerant before using any strength of transdermal fentanyl or hydromorphone extended release. For other extended release opioid products, patients must be opioid tolerant before using certain strengths or certain daily doses. And please see the other sections for that. Patients are considered opioid tolerant are those who are taking at least 60 milligrams of oral morphine a day, 25 microgram transdermal fentanyl patch, 30 milligrams of oral oxycodone a day, 8 milligrams of oral hydromorphone a day, 25 milligrams of oral oxymorphone a day, or an equal analgesic dose of another opioid for 1 week or longer. Individually titrate to a dose that provides adequate analgesia and minimizes adverse reaction. The times required to reach steady-state plasma concentrations are product-specific. Refer to product information for titration interval. Continue to reevaluate to assess the maintenance of pain control and the emergence of adverse events. Remember that the starting dose for extended release long-acting agents should be individualized. During chronic therapy, especially for non-cancer related pain, periodically reassess the continued need for opioids. If pain increases, attempt to identify the source while adjusting the dose. When an ERLA opioid analgesic is no longer required, gradually titrate down to prevent signs and symptoms of withdrawal in the physically dependent patient. Do not abruptly discontinue these products. ERLA opioid analgesics are indicated for the management of moderate to severe pain when a continuous around-the-clock opioid analgesic is needed for an extended length of time. Limitations on usage: not for use as an as-needed analgesic, not for mild pain, not for use in treating acute pain. Remember, dosage reductions are needed for hepatic or renal impairment. And remember your relative potency to oral morphine. These ratios that were provided earlier are intended as general guidelines. Follow conversion instructions for individual products. And remember about incomplete cross-tolerance and interpatient variability requiring the use of conservative dosing when converting from one opioid to another. ERLA opioid tablets and capsules must be swallowed whole. Crushing, chewing, breaking, cutting, or dissolving may result in rapid release and absorption of a potentially fatal dose of opioid. For patients who have difficulty swallowing their medication whole, certain capsules can be opened in pellets sprinkled on applesauce for patients who can reliably swallow without chewing and used immediately. Again, you must see the product insert for which capsules can be done that way. Exposures of some products to alcoholic beverages or medications containing alcohol may result in the rapid release and absorption of a potentially fatal dose of opioid. Dispose of unused product in drug take-back programs or prescription drug drop boxes. When not available, flush down the toilet. Transdermal dosage forms must not be cut, damaged, chewed, swallowed, or used in ways other than indicated, since this may cause choking or overdose resulting in death. Application of external heat sources to the transdermal application site and surrounding area, fever, and exertion can increase absorption of the opioid, leading to fatal overdose. Patients with fever must be monitored for signs and symptoms of increased opioid exposure. Instruct patients to prepare skin by clipping, not shaving hair, and washing areas only with water. Transdermal products with metal foil backings are not safe for use in MRI scanners. Patients should dispose of unused product at drug take-back programs or prescription drug drop boxes. When not available, flush down the toilet. Used patches should also be flushed to avoid accidental exposure. Remember that concurrent use with other CNS depressants, sedatives, hypnotics, general anesthetics, antiemetics, phenothiazines, other tranquilizers, and alcohol can increase the risk of respiratory depression, hypotension, profound sedation, or coma. Reduce the initial dose of one or both the agents. Partial agonist and mixed agonist antagonist analgesics, for example, buprenorphine and pentazocine and buprenorphinol, may reduce the analgesic effect or precipitate withdrawal symptoms. Avoid concurrent use. Opioids may enhance the neuromuscular blocking action of skeletal muscle relaxants and produce an increased degree of respiratory depression. Concurrent use with anticholinergic medication increases the risk of urinary retention and severe constipation, which may lead to paralytic ileus. Use in common opioid-tolerant patients. For use in opioid-tolerant patients, hydromorphone ER and transdermal fentanyl products are contraindicated for use in opioid non-tolerant patients. I have seen patients die when they were given these drugs before, when they had not taken them before. These products are only for use in opioid-tolerant patients at all strengths. See the product insert for which ERLA opioid analgesic products which have strengths or totally diluted doses only for use in opioid-tolerant patients. These opioid analgesics are contraindicated in patients with significant respiratory depression, acute or severe asthma in an unmonitored setting, known or suspected paralytic ileus, a known hypersensitivity to any of the components of the analgesics, including the respective active ingredients, or in any situation where opioids are contraindicated. Please see the product insert for additional information.
This is about specific drug information for the extended release long-acting opioids and analgesic products. Now, some of you might say, I don't prescribe these drugs, I don't use these drugs, or I'm not able to prescribe these. Either way, you're still going to see patients with these drugs, so you've got to know about these drugs and understand them, know the side effects with them, because you're still going to see patients whether you've prescribed them or somebody else has, so you need to know that. So we're going to look at some of the specific characteristics of some of these drugs that you can see here. We'll look at the formulation, their strength, their dosing interval, and specific things about those, and some of the relative potency to morphine and some key instructions. So these are looking at specific drugs, and first off, we're going to look at morphine sulfate. The initial dose in this in people who are not opioid tolerant, that you're not bringing off something else, is 30 milligrams. Your minimum day to titrate is 3 days. When somebody calls you in a day or 2 days and say, I'm not getting adequate relief, you don't bump them up just like you don't do the Analgesic patch. It's a 3-day interval. Again, this is when you swallow the capsule whole. You don't chew it, flush it, or chew it or dissolve it. This one is one, though, if you've got a patient that has trouble swallowing, you can open this capsule and you can sprinkle the pellets on applesauce for those who cannot swallow without chewing and use it that way. So this is one of those you can do that. You just do have to watch that. The maximum dose of this is recommended to be 1,600 milligrams due to renal toxicity. And the renal toxicity, this drug is Avenza. What's interesting, this does not have an upper level dose because of the morphine. It's because one of the components of Avenza is fumaric acid. So the toxicity is actually from the fumaric acid. So that's why there's an upper level on this dose that you can take it with, because you get renal toxicity with that. Remind them again with this drug that you should not use alcoholic beverages along, because you increase the rapid absorption of this drug and potentially fatal dose. There are 90 milligram and 120 milligram capsules for use in opioid tolerant patients, but again, otherwise you start with a 30 milligram. And this is the long-acting morphine sulfate known as Avenza. The Butrans is getting in more and more use here. This is one transdermal system every 7 days. The initial dose in this is less than equivalent to 30 milligrams of morphine equivalents. In mild to moderate hepatic impairment, you only start with 5. When you're converting somebody who's taking anywhere from 30 to 80 milligrams of morphine equivalents, you first taper to 30 milligrams of their morphine equivalent, and then you can titrate them starting with a 10 microgram per hour of the Butrans. Again, with this, you titrate after a minimum of 72 hours to do a dose adjustment. You have to be careful with this. The maximum dose is 20 micrograms, and this is due to the risk of QT prolongation. Remember, you only provide this, put this on sites that's recommended in the PI. You put it on intact, non-irritated skin so that the absorption is stable. You can prep the skin by clipping the hair and washing the site with water only. Then you rotate the application site, and it's recommended there be a minimum of 3 weeks before you reapply it again to the same site. And of course, with all the patches, again, you do not cut these. You should avoid exposure to heat because that increases the absorption. And again, this is one of those patches we mentioned earlier that you fold on the adhesive side and you flush down the toilet. On the transdermal system, also remember this, that the CYP3A4 inhibitors can increase the levels of the buforphine, and the inducers may decrease the levels. So you got to also be careful with the benzos with this drug in causing respiratory depression, and also other antiarrhythmics, particularly class 1A and 3, because you can get into the QT prolongation with that, so be very careful. The 10 microgram and the 20 microgram is only for use in those who are opioid tolerant patients. Again, the things to watch for, particularly in this drug, is QT prolongation, hepatotoxicity, and you got to watch for application site skin reactions. Methadone, I know you haven't heard anything about methadone, and all of you are going to go home and prescribe methadone to the first pain patient you walk in. But we will go ahead and talk about this. Its half-life of it, the dosing interval with it is 8 to 12 hours. The initial dose in those who are not opioid tolerant is 2.5 to 10 milligrams. When you look at that, the problem, as you know, and you've heard over and over, there's a high interpatient variability in the absorption, in the metabolism, and the relative analgesic potency with this drug. And if you are treating this patient for opioid detoxification or their maintenance treatment, this can only be provided in a federally certified opioid addiction treatment program. So don't ever let the DEA think, if you're not qualified to do that, that you're treating somebody for detoxification or maintenance treatment. The pharmacokinetics of this drug are just very complex. You've got inducers, you've got inhibitors. If they got HIV and the antiretroviral agents, they have kind of mixed effects on the methadone levels. Then you've got the risk of QTC prolongation. And then, of course, the benzodiazepines markedly increase the respiratory depression with this drug. Just make sure the patients read the PI fully, make them aware of the problem with the respiratory problems and particularly the heart problems. The interesting thing, again, about this drug is the peak respiratory depression occurs later and it persists longer than the analgesic effect. So they've got the analgesic effect, but that respiratory depression is later on. And the clearance may increase also during pregnancy, and then there's also the possibility of the false positive urine drug screen. Fentanyl or Duragesic, the transdermal system, again, this is 72 hours, 33-day replacement of this drug. It's got specific recommendations in the PI. With anybody with hepatic or renal impairment, you should reduce it by 50% and avoid if it's very severe. Again, the same way, you can prep the skin by clipping the hair, rotate the site of application, titrate no less than 72-hour intervals, and make sure you don't cut. Avoid exposure to heat, and be very careful handling this in accidental contact when holding or caring for children. And then dispose again, fold adhesives together, and then you can flush that down the toilet just like you could with the Butrans. With patients who are not opioid tolerant, you just got to be very careful with them, start at the very lowest dose, and it's not for patients who are not opioid tolerant already. It's not for management of acute pain or intermittent pain or people who you're just going to treat for a short period of time. It's not for postoperative pain, it's not for outpatient pain, it's not for day surgery pain or mild pain. Again, you got inhibitors and you got inducers. All doses, again, should be indicated for opioid tolerant patients. Just be careful with this drug with the accidental exposure by unwashed hands, unclothed on the application site. You can increase the drug exposure by increasing body heat or temperature or fever. Bradycardia can also happen along with the application skin site reactions. Another long-acting morphine with naltrexone in it, Embeda. You heard about that. Jerry talked about that earlier. The dose here is, it can be once a day or it can be a BID dosage every 12 hours. The first dose, is when this is the only opioid they're taking, is 20 milligrams. Again, you don't titrate this but every 3 days. They need to swallow these capsules whole and not chew them or crush them or dissolve them. This releases the morphine immediately and gives them a fatal overdose. But they can open this capsule, just like you could the Avenza. They can open this capsule, sprinkle the pellets on applesauce for patients who have trouble swallowing. So this is one of those drugs you can do that with. Again, warn them about the problems taking alcohol with it. You got to be particularly careful with some drugs like quinidine that increase the absorption of this drug. So just be very careful with that. So you're going to see more and more of these newer drugs coming out as we go along. This is another hydromorphine long-acting, Exaljo. Again, look at the PI. People with moderate hepatic impairment, you start at 25% of the dose that you normally would. If they got renal impairment, start at 50%. You titrate again this at 3 to 4 day intervals. They can swallow the tablets whole, but do not chew or crush these. And do not use this in patients who have a sulfite allergy, in other words, anything because of contains sodium metabisulfate. All the doses for opioid tolerant patients only. And again, the big thing you watch for is anybody who has a sulfite component allergy. Another long-acting morphine is Cadian. This is dosed again once a day or BID. This can be titrated at 2 day intervals. You can swallow the capsules whole. Again, do not chew or crush. But this is another one that you can open the capsule and sprinkle the pellets. avoid alcohol again with this. There's a 100 milligram dose, and there's a 200 milligram capsules that are used for opioid tolerant patients only. MS Contin is probably the one of these that you're probably as much or more familiar with than the others, as it's been out a good while. This you can dose every 8 or every 12 hours. This you can titrate at 2-day intervals. Again, you swallow the tablets whole, and these got 100 and 200 milligram tablets that you use only in opioid tolerant patients. This is one of the newer drugs, Nucynta ER extended release. This is an every 12-hour drug. The dosage is normally 50 milligrams every 12 hours as the initial dose in your opioid non-tolerant patients. Then you can titrate by 50 milligram increments using a minimum of 3-day intervals with that. The maximum dose is 500 milligrams. You swallow the tablets whole. You take the tablet one at a time with enough water to ensure complete swallowing immediately after placing in the mouth. You dose it once a day if they have moderate hepatic impairment, and with them you should not go over 100 milligrams max, and avoid if they have severe hepatic or renal impairment. Again, like all these, avoid alcohol because of the risk. And this drug does have a risk of serotonin syndrome and also has a risk of angioedema, so just keep that in mind when you're using this drug. I think Jerry talked about Opana, the regular Opana and the abuse, and now you have the Opana ER. Now this is every 12-hour dosing with this. You start with 5 milligrams every 12 hours of the initial dose in opioid non-tolerant patients, and then with those who have mild hepatic impairment or renal impairment, you start with a lower dose. You swallow the tablets whole. You take one tablet at a time, again with enough water to make sure they swallow that. The minimum time between titration is 2 days, and if they have moderate severe hepatic impairment, they're contraindicated. There's no product-specific contraindications to this drug. OxyContin is the drug that probably gets the most press. It's oxycodone CR. This is dosed every 12 hours. For opioid naive patients, you initiate your treatment with 10 milligrams every 12 hours. Then this you can titrate every 1 to 2 days. Hepatic impairment, you need to start with 1/3 to 1/2 of the usual dose. Renal impairment, you need to start with 1/2 of the dose. If people have difficulty swallowing, underlying GI disorders that are predisposed them to obstruction, you probably might want to consider another drug. They have to swallow these tablets whole. They take one tablet at a time again. You have the CYP3A4 inhibitors and the inducers you've got to be careful with. A single dose greater than 40 milligrams or total daily dose greater than 80 should be used in opioid tolerant patients only. Be careful about choking, gagging, regurgitation, tablets stuck in the throat, and difficulty swallowing the tablets. So it's contraindicated in any patients with GI obstruction. So in summary, we've talked about how to understand to assess patients for treatment with long-acting opioids, how you should be familiar with how to initiate therapy, modify the dose, and continue the use of long-acting opioids, how to manage ongoing therapy with long-acting opioids, how to counsel patients and caregivers about the safe use of the opioids, and be familiar with general and product-specific information concerning long-acting opioids. And with that, we have actually got you out of here 9 minutes early. Thank you so much.
Thank you.